intervention. I want to understand that we are all coming from lunch, and so we are very full, and some of us are feeling lazy. In fact, how we would wish to be on our beds. But hey, for the love of God and for country, we have to avail ourselves for this important meeting. And so I'll ask that we all join forces to be as snappy as we can so that we can all leave here on time. Without much ado, ladies and gentlemen, I'll call on Reverend John from the Ministry of Health to give us a word of prayer. Let's welcome him with a resounding hand.
Shall we respectfully rise for prayer? And so, Heavenly Father, we are grateful for this opportunity this afternoon. Thank you for bringing us together safely. Your word says to commit our works into your hands, and you will see them successful. We pray, Father, come and take charge of proceedings. Lead us and grant us grace and wisdom, so that at the end of the day, glory and honor shall be given unto your name. This is a minimum we ask through Jesus Christ. Amen.
Thank you very much, Reverend John, for calling the Spirit of the Holy God into our presence here this afternoon. Distinguished ladies and gentlemen, it is my singular honor to introduce to all of us some esteemed dignitaries in our midst this afternoon. I know we have here our partners from WHO, from the Ghana Health Service. We have here participants from UK International Development. We have here health workers. The technical working group is also here. We have some directors and unit heads from the Ministry of Health. I would also go ahead and introduce to you some directors that I can see on the high table from the Ministry of Health. We have here Dr. Ignatius Savini-Bonu, Director Allied Health. Thank you so much for coming, sir. We also have here from the Ghana Health Service, Dr. Franklin Isidu-Bekwe. Thank you for coming. We have here Dr. Peter Pepra, Ghana Statistical Service. Thank you for coming, sir. Dr. Frank Woolley, World Health Organization. Thank you for coming, sir. Mr. Dominic Farwell from the Health Advisor, FCDO Ghana. Thank you so much for being here with us this afternoon. We also have here Dr. Dennis Odai-Lai. Thank you so much for coming, sir. We also have here the representative of the Minister for Health, Dr. Daryl Sosei, the technical advisor to the Honorable Minister, Dr. Daryl Sosei. Thank you so much for coming, sir. I can see Dr. Morrison, Ma'am Lee. Thank you for coming. So like I said, all directors from the Ministry of Health duly recognized. It is now time to be officially welcomed to this meeting and also to set the tone for us. And I have the singular honor to introduce to you the one who will be giving us the welcome address. Before he comes, a little profile about him. He is currently the Acting Director, Technical Coordination Directorate at the Ministry of Health, as well as the Director for External Health Cooperation. He is the Chairman of Ghana's Intra-Country Coordination Committee for Neglected Tropical Diseases. He is a board member for the National Vaccine Institute. He is also a board member of the KCCR of NUS, and also a board member of the Nurses and Midwives Council. He also serves as a member of the Selection Committee for the Excellence Award for Health Workers. He is an executive member of the Northern Development Forum. He has been part of ministerial and presidential delegations to several local and international conferences and workshops. From 2006 to 2012, he served as the national coordinator for Lavicidine, the project for malaria and other diseases control at the Ministry of Health. And in 2010, He was a member of the advisory team for WHO Africa region to prepare guidelines for larvicidin activities in Congo, Brazzaville. In 2013, he was tasked with additional responsibility to coordinate the Human Medical Brigade in Ghana. In 2019, he was appointed as the director for External Health Corporation. From 2000 to 2008, he was a permanent guest on the national TV for newspaper review as a panel member. He has acquired several postgraduate certificates, and just to mention a few of them, they include implementation, science leadership in management, monitoring and evaluation, among many others. Distinguished ladies and gentlemen, with a thundering round of applause, help me welcome Dr. Hafiz Adam Tahiri, Director Technical Coordination at the Ministry of Health. He is representing the Chief Director Alhaji Hafiz Adam.
Thank you very much for those kind words. At a point in time, I didn't know I was the one you were talking about. Excellencies, heads of agencies of the ministry, representatives of the development partners sector lead, development partners in health, representative from academia, distinguished guests, friends from the media, directors from the ministry and Ghana Health Services, our esteemed principal investigator, distinguished ladies and gentlemen. Good afternoon to you all. Oh, as if we haven't taken lunch. Good afternoon to you all. Now I can hear you. So it is indeed a pleasure to be here today as we gather for this significant occasion. The dissemination of the findings from the nationwide STEP survey on non-communicable diseases risk factors in Ghana. On behalf of the Ministry of Health, I want to extend our deepest appreciation to all our partners, stakeholders who contributed to the success of this survey. As many of you are aware, NCDs such as heart disease, stroke, diabetes, cancers, and respiratory diseases represent a growing public health challenge, not just in Ghana, but globally. The findings we are about to discuss today are the result of Ghana's first nationally representative study on NCD risk factors. This study serves as a crucial baseline that will guide the future of our health policies and frameworks aimed at mitigating the burden of NCDs in our country. Distinguished ladies and gentlemen, the collaborative effort between the Ministry of Health, Ghana Health Services, Ghana Statistical Services, and the WHO marks a pivotal milestone in the response to rising incidence of these diseases. I commend each of you for your availability, your contribution, and commitment to this initiative. Distinguished ladies and gentlemen, our principal investigator, whose expertise and dedication have been instrumental in this study, will soon walk us through the key findings. This presentation will set the stage for discussions that will help us shape the policies and actions needed to combat NCD's burden and improve the health and well-being of our people. Distinguished ladies and gentlemen, as we embark on this journey to strengthen the public health system, your insight, participation, and contribution during this session will be vital. Together, we can continue to forge strong partnerships and develop innovative strategies to address the health challenges posed by NCDs. Distinguished ladies and gentlemen, as I conclude, I once again want to thank you all for being here and for your unwavering support. I look forward to a productive session filled with meaningful discussions and actionable outcomes. May I this Bianca, thank you very much for your attention and may God bless us all. Thank you.
Thank you very much, Doc, for setting the tone for this meeting. At this point, I would want to introduce all heads of agencies here present. Please give us a wave for us to see that you are here. All heads of agencies here present. You are welcome. Thank you so much for joining us here this afternoon. At this point, we'll have some solidarity messages from our partners. And I will begin with Dr. Franklin Isiedubequin from the Ghana Health Service. He is the director in charge of public health. Let's welcome him with a round of applause.
Thank you very much. So let me stand on the existing protocol that has been established by Dr. Hafiz. It is great to be here today for the dissemination of the findings of our nationwide NCD risk factor assessment survey. This journey was long and winding. However, through perseverance, dedication, and commitment, we have been able to surmount the challenges. The growing burden of NCDs is not lost on us. What makes these diseases particularly concerning is that they are largely preventable. Primary risk factors for NCDs include lifestyle choices and behaviors, such as unhealthy diets, physical inactivity, tobacco, and harmful use of alcohol. Environmental factors such as air pollution and genetic predisposition also play a role. This is why the NCD risk factor assessment survey is crucial. The survey gives us the opportunity to identify these risks, map out which gender or age groups are most affected, allowing us to target preventive interventions. The survey provides a snapshot of the behaviors, environmental influences, and socio-economic conditions that contribute to NCDs. Conducting an NCD risk factor assessment survey is just the beginning. It is essential that the data collected is used to make informed decisions to improve our national response. I want to emphasize that the fight against NCDs is a collective effort that requires participation from every sector of the society: individuals, families, businesses, schools, and the government at large. Together, we can reduce the burden of NCDs and promote healthier, more vibrant community. In closing, I would like to thank our dear friend and colleague, the late Prof. Pangu, whose tireless effort triggered the conduct of this survey. To our partners who came on board and stuck with us through all the challenges to ensure that the survey was successfully conducted, we say thank you and Ayuko. Your work is invaluable in helping us better understand how we can prevent and manage NCDs. By identifying the risk factors today, we can build a healthier tomorrow. Thank you.
Thank you so much, Doc. It's now the turn of Dr. Peter Pepra from the Ghana Statistical Service.
Good afternoon, everyone. And I will also crave your indulgence to allow me to stand on the existing protocols to make my solidarity message, but on behalf of the government statistician. Unfortunately, he is not in the country, and he wished he was here to be part of this success story. It is a privilege to be associated with this success story of the first step survey on non-communicable diseases risk factors conducted in the country in 2023. In unity, we must strive for a healthier future. The Ghana Statistical Service stands in solidarity with the World Health Organization, the Ministry of Health, and the Ghana Health Service in achieving this milestone for conducting a nationwide representative STEPS survey. The findings from this report will serve as a crucial foundation for enhancing our understanding of NCD risk factors and strengthening our efforts to combat these diseases in our country. The good news is that it is a representative sample survey. Therefore, it provides grounds for regional variation in understanding and appreciating varied behavior and lifestyle to aid targeting and intervention. The survey results are invaluable in shaping policies and interventions that can promote well-being and longevity for all and not only for monitoring programs. As we move forward, let us work hand in hand to promote healthier lifestyle and a more resilient society. We need to let the public understand and know the dynamics of the causes of widespread non-communicable diseases and their risk factors among the population and how they can be prevented. Fellow researchers gathered here and the WHO Research Unit, let us integrate the data from this survey with other rich data sets from the Ghana Statistical Service, the Ministry of Health, and the Ghana Health Service, and carry out further studies on non-communicable diseases in the country. By doing so, we can derive meaningful insight that will inform policy decisions. Together, we can make a significant impact for our country, Ghana. Kudos to the technical working group. Thank you very much.
Thank you very much, Doc. And now from the World Health Organization, let's welcome Dr. Frank Luli.
Good afternoon, colleagues. I'm really privileged to speak because after lunch, I need to be standing up. You'll know it when you get older. Yes. The representative of the Deputy Minister of Health, Dr. Darius Osei, representative of the government statistician, the directors of the Ministries of Health and Ghana Health Service, and also heads of agencies, fellow development partners, representatives from civil society, and the many NGOs that are in the room, our friends from the media, and also members of the technical working group. Good afternoon, ladies and gentlemen. I'll start by relaying the greetings from our WHO leadership, from the regional office, Dr. Matshidiso Rebecca Moweti, and also Dr. Tedros at headquarters. The reason I'm doing that is because in Ghana, we've achieved a milestone that WHO has been pushing all countries to do. And Ghana has really come up with a very good success story with a successful result, and we can't wait to see the findings of the study. As you all may be aware, non-communicable diseases as something we cannot ignore anymore. The reason is more than 40% of deaths globally, regionally, and I think in Ghana now, are due to non-communicable diseases. As WHO more than 10 years ago, they've come up with resolutions for countries to work and address this challenge. And we know that many countries have come up with strategies to actually address NCDs. But this is something we cannot ignore anymore. I was given some notes here, and it says the outlook for NCDs in West Africa, including Ghana, indicates a significant and rising burden. 41 million deaths each year globally are occurring due to NCDs, and 85% of them are premature, and they are occurring in low and middle income countries. We know Ghana is a middle income country. So this is our problem. And I've said in Ghana, approximately 45% of deaths with cardiovascular disease, cancers, chronic respiratory diseases, and diabetes are the major contributors. Distinguished ladies and gentlemen, key risk factors for NCDs include unhealthy diet, physical inactivity, tobacco use, and harmful use of alcohol. These factors are exacerbated by urbanization, changing lifestyles, and limited access to healthcare services. We need comprehensive strategies to address these risk factors because it's crucial for mitigating the NCD burden in Ghana. To do this, quality and timely data on trends in NCD's risk factors is essential. Thus, the conduct of the first nationwide risk factor survey using the WHO stepwise approach and tools to NCD's surveillance. The results of this survey will also be key in evaluating Ghana's 2022 to 2027 multi-sectoral action plan for NCDs. I congratulate the Ministry of Health, Ghana Health Service, Ghana Statistical Services, and development partners for supporting the implementation of the first nationwide STEP survey. I have confidence that the Ministry of Health will fully institutionalize regular conduct of the STEP survey, and the rich data will be utilized effectively by both health and non-health sectors to really design appropriate interventions which will ultimately reduce the NCD's burden in Ghana. Now, let me stop here. Let's get to the findings. Thank you very much.
Now, the last but not the least person to give us a solidarity message is Mr. Dominic Powell, the Health Advisor, FCDO Ghana. Sir, please help me pronounce your name properly.
Dominic Farrell.
Farrell.
Yeah.
Right.
Thank you very much. Ladies, gentlemen, it's a privilege to join you today, and I hope that you'll permit me to stand on existing protocols. The UK is pleased to stand in solidarity with our partners in Ghana and have supported, alongside Norway, the development and dissemination of the maiden survey of NCD risk factors in Ghana. We extend our thanks and gratitude to the principal investigator, enumerators, and participants that made this happen, and to the Ministry of Health, Office of the President, Ghana Health Service, WHO, University of Ghana, Ghana Statistical Service, Confidential Teaching Hospital, and 37 Military Hospital for their technical leadership and guidance. As we know, the burden of non-communicable diseases is rising. A baseline understanding of the risk factors that are contributing to this is a fundamental step in being able to take effective action to promote better health and prevent ill health. There were three things that really stood out for me from the headlines of the report. Firstly, addressing these risk factors is a multi-sectoral effort. Smoking exposure in the workplace, access to nutritious and affordable food, opportunities for exercise and sport, and addressing stigma around mental health. All of these are beyond the gift of the health sector alone, as Dr. Lude just alluded to. Secondly, it shows how important it is that people are empowered to take charge of their health. Access to information and to screening means that people can manage their risks and seek help early. Developments such as the NHIS annual health checks are a welcome step towards enhancing prevention and early detection. And finally, there's a need to ensure that individuals can access the services they need to manage their risks and conditions. The report sets out clearly some of the gaps, with high levels of uncontrolled hypertension, low uptake of insulin, and low levels of seeking mental health support. So fundamentally, this survey underlines the importance of the efforts Ghana is making to enhance health promotion and prevention. And we hope that this report provides the basis for targeted, cost-effective action that empowers Ghanaians to take charge of their health and reduces the burden of NCDs. Thank you.
Thank you very much. Distinguished ladies and gentlemen, it is now time to delve into this afternoon's discussion. We are going to have a presentation on the summary of findings from the STEPS survey. And we have to note that the survey is providing us with valuable data to inform evidence-based policies, programs, and interventions aimed at reducing the impact of NCDs on our citizens. And so it is my pleasure to invite to the podium Dr. Dennis Odai Lai, Principal Investigator. He's going to give us a presentation on the summary of findings. The Principal Investigator, is it from the Ghana Police Service?
I'm not sure. Well, my father used to be a policeman, so maybe that's where my status as an investigator is coming from. So thank you very much. I guess I'll stand on the existing protocols and present on behalf of the team. We'll see our membership maybe at the tail end of the presentation. So this is going to be the outline of my presentation. We'll have a brief background, or probably not too brief. We'll look at the methods, the results, what our next steps are, conclusion actually, and then our next steps. So I think earlier speakers have highlighted the fact that it's something countries do, and Ghana had not done a nationwide step survey. But one of the things I used to be the NCD program manager, and I remember when I traveled to other countries for programs, one of the first things countries presented was their NCD step survey, what their risk factors were, and what they've been doing as a result of those findings. And here I was, Ghana NCD program manager. There was no such thing to present. So you had to be combing for bits and pieces of research that had been done in places within the country and try to put them together. Just a small presentation, you have to do a systematic review. And so that was a challenge. And for me, it just made me take that task that I'm going to push for us to get the NCD step survey done in Ghana. And as Professor Pandru, may he rest in peace, was very instrumental in pushing this agenda as well. So there's assumption that we're experiencing an increasing burden, and I'm using assumption here lightly because you need evidence. And so there are pockets of them, but does that mean that it's a problem in Ghana as we would want to believe it is? So NCD on the increase in addition to deaths as a result of NCDs. We have varied evidence, as I indicated, and they were largely not nationally representative. And so you might do a study in a certain group, the evidence might point to something, but it may not necessarily be applicable to their country. What that also meant was that our decision making was not data driven. And so we needed to look at that. What, for example, if we ask if smoking is a problem in Ghana, we'll probably say no. But what is our basis? Is it because when we travel, we smell tobacco more than we do when we are here? And so those are things that will limit the kinds of interventions we'll put in place. And one of the things I would want to highlight, especially in relation to tobacco, is one of our findings in this study. Hopefully, moving forward, as far as smoking in some environments are concerned. So the W2 Step Survey is one of the good tools for evidence generation as far as looking at issues around NCD prevention and control. And Ghana had done one in 2006. Dr. Billy Bosu, then the NCD program manager, I think he's currently with WOW, did a sub-national survey and it was only in Greater Accra region. So again, that wasn't very representative of the country. I don't think Greater Accra represents the country. And there have been several efforts, as I mentioned, to get this done. Fortunately, in 2003, we were able to get this up. So this is just an image of the summary findings from that. So why, again, we have an NCD policy from 2022. The 2012 one, which was what was in existence when I was the NCD program manager, again, I realized that all the 4 objectives of that policy required data to monitor progress. And I mean specific data, not implied data. So we needed that. And in our current policy with 5 objectives, 3 of them have clear requirements for data to be able to monitor progress. And within them as well, we have several activities or targets that have been set that require, for example, us having a baseline to be able to then tell whether we're making progress or we're retrogressing. So this was also very important. Now, it's not to say that there was absolutely no data on NCDs in Ghana or the risk factors. So I'm sure we all have heard, or some of us might have heard of the Ghana Demographic and Health Survey. In 2014, indicators for non-communicable disease were included and was repeated in the latest one as well. But for those of us who may be very familiar with the STEP survey, there's a limit to age. So for females, it was 15 to 49. And then for males, it was 15 to 59. Now, for non-communicable diseases, we know that the older the age group, the higher the likely incidence or prevalence. And so that meant, again, that even though this was nationally representative, it still didn't take into consideration the population that were most at risk. So yes, it did give us some evidence of what the situation may be, but it didn't change. It didn't cover all the bases we would want covered. And then globally, we know that we have the Sustainable Development Goals, Goal 3 of which is focused on health, ensuring healthy lives, and promoting well-being at all ages. And amongst these are specific targets that are aimed at non-communicable diseases. So for example, we want to reduce by 1/3 premature mortality from non-communicable diseases, which presupposes that we have a baseline. And this has to be through prevention and treatment. strengthen prevention and treatment for substance abuse, and in particular harmful use of alcohol as well. So that is there. If we don't know where we are standing as far as harmful use of alcohol is concerned, then our measurement of our progress towards achieving this target, for example, is limited. And there are others as well. I won't run through all of them, but just to highlight the points that SDGs are one of the reasons why we think that this survey was very important. Again, we've mentioned the fact that baseline data is key. And for us to be able to monitor what is going on, we need that data. And the steps provided us this opportunity to provide this nationally representative data set on NCD risk factors. The steps is just, no pun intended, the first step. So the STEP survey is not going to solve NCD problems. It's actually going to give us a basis to now start asking questions to be able to solve those. So all of these, I think, I've highlighted earlier on. But most importantly, now my successor, Dr. Kome, can also go for programs. And in the background to the country, she can also present Ghana STEP survey findings, which I think will be good. So that's on the lighter note, but I think that it's important. So what did we do? These clearly show, the red dots show the places we took, we conducted our surveys. So it was nationwide in all our 16 regions. We had 385 enumeration areas. We selected 5,775 participants. And for those of us who have done research, we know that you will never get the same number. So these are the numbers we were able to interview: 5, 4, 3, 8, and do the other relevant data collection. The age range was from 18 to 69. So remember I mentioned in the demographic and health surveys, 15 to 49 for females and 15 to 59 for males. So this is a much wider age group. And if I want to be political, I'll say that the life expectancy is within this age group as well. And so that means that we've covered everybody there is to cover. So data was collected. These days we work on electronic. So the days where we were collecting with paper, Dr. Pepra would tell us that they had a lot of paper those times to work with. But now we're using Android tablets. And so this is what has been pseudo-named E-Steps. So we measured blood pressures for respondents in this survey, and we used a digital spec, so we didn't use the mercury one. Let's just bear that in mind. We also used a glucometer to measure the fasting blood glucose, and we had what we call the CardioCheck Plus, which was used to check for the total cholesterol and HDL cholesterol. We had a portable weighing scale and a stadiometer, which I have to admit sometimes was work for the field officers, and there was some gender bias. I realized in the places I went that it was always the men who were carrying the scale and the stadiometer. I'm sure what men can do, women can do better. So maybe next time we'll see that. So what were the steps? So it's 4 steps for a reason. So there are various steps. The first one, step 1, is behavioral. And again, WHO has a package. So there are 3. There's a core, which means that you must do that. So if you say you are doing a step survey, the core must be done. And then there's the expanded, which is additional. And then if you want to go further, okay, then there are the optional. So the core one is basically interview based. So we ask questions and people give us the information required. So questions around the basic demographic information: tobacco use, alcohol consumption, diet, physical activity, history of raised blood pressure and the others, lifestyle advice, and for women, questions about cervical cancer screening. And then for the expanded, so these are the ones we did. This is not the whole package, but these are the ones we did for the expanded. So we included extra information as far as the demographic information is concerned on school, years at school, ethnicity, marital status, and the likes. And as well as questions about sedentary behavior, salt consumption, and others. And then we also included in the optional questions on mental health, oral health, and then other household um, amenities. The step 2 is focused on physical measurements. So this, we are looking at weight and height, and then the waist circumference, and then the blood pressure. And then we had an expanded hip circumference being measured. And the third, the step 3, is the biomedical measurements. So fasting blood sugar, total cholesterol. I have this in yellow because we started, but we had to abandon it for operational reasons. Then the expanded was the HDL cholesterol. So we analyzed the data using the P4 version 3.4.8 and SATA version 15. Data was weighted, and I'm sure those of us who like statistics, those who are not like me, would know what goes into things like this. But it's just, as Dr. Pepra said, to reflect on the population so that we can be able to say this, because it's not possible to even check 1% of us. So what did we find? Tobacco use. So overall tobacco use, and tobacco use here is not only talking about cigarette smoking. So that is 4.8%. I think the key thing here is clear. Males, so about 1 in 10 adult males use tobacco, compared to about 3 in 100 or less. Sorry, 3 in 1,000 for females, right? And then if we look at current tobacco use, for those who smoke, shisha, 7.8%. And the reason why this is more important is because it's in this age group, they are accounting for 12%, 12.7%. But even more, within this age group, females are almost 2/3. So if you pick 3 youth in this age group who use shisha, 2 of them are likely to be female. So let's let that sink in. And I've said this, that once women do things, the likelihood that men will follow. I mean, if you go out with a lady and she's smoking, and you are interested in the lady, this one is digression, it's not part of the investigation. So once we have this population being the highest proportion smoking shisha, then I think that the risk is there. The other worrying finding was the fact that more than half, so 64.8% of current smokers actually do it daily. People will say that dose-response relationship between tobacco use and getting the complications is not always the case, but most of the time it is the case. So this is the other part. And I mentioned earlier on that one of the things I would personally would want to see changed in this country as far as this is concerned is that 1 in 5 of our respondents were secondhand smokers. So they are exposed to secondhand smoke where they work. And there are more males than females who are exposed. But the important thing is that close to 20% are exposed to tobacco, not because they are smoking or using it themselves, but because others are using it. So the point about allowing smoking in designated places is probably something we'll have to look at as a country. Alcohol consumption. So we used the past 30 days as a reference point for people who take in alcohol. And that was a little under 23%. So less than 1 in 4 have taken alcohol in the past month. Males were more, so 30.6 compared with 14.5 for females. And rural dwellers were more. I thought that maybe affluence was associated with increased consumption, but maybe our dynamics are different compared to other places. And so for us, it was more among the rural ones. The other one is heavy episodic drinking. So this is taking more than 6 units of alcohol at a sitting. And 6 units of alcohol, if I use beer, for example, it's about 3 large beer bottles. So if somebody sits and drinks go down style class 3 bottles, that or more, then that will be considered heavy episodic. Or 6 tots. Now the tots, I think depending on the country, they are different. So I'll use a 25 ml so that we know the tots we are talking about. Because some countries, their tots are bigger than others. So, but we're saying 25 ml. So if a person takes 6 of those or more, then that qualifies as such. And as we can see, it's 2.5%. It's still more in males, but we can see that the women are also in their own space as far as heavy episodic drinking is concerned. Lifetime abstinence. So colleagues on the committee, in the technical working group, some were doubting this figure, but close to 44% of the Ghanaian population doesn't take, at least based on this survey, a lifetime abstinence. So they don't take in any alcohol. So maybe when we finish, at the end, we'll do a survey. So when we are exiting, we'll be asking each one of us to find out whether it applies. And even with that, so even after this, for those who have abstained for 12 months, so some go on break when they are drinking, they go on alcohol drinking break. So those who have been abstaining for 12 months is about 19.8. So quite a significant proportion are either lifelong abstainers or abstaining for fasting. Now, diet. So fruits. Consumption of fruits on the average in a typical week was found to be 2.2 days. For some of us, maybe it's workshops like these that we are forced to eat fruits. Okay, so 2 days a week. So in 7 days, we're only consuming fruits twice, average. Vegetables, maybe because our food always have vegetables in there. But this is also something I think we'll have to look at on the research angle, because not all vegetables consumed are necessarily vegetables. And maybe because my British friend here, we don't eat fish and chips here. So maybe the option to not eat vegetables in a day is probably not an option. Most of our foods have vegetables in there. So maybe that's why we're seeing this. But as I said, the processing of the vegetables, does that result in the benefit we are anticipating? So I don't think we should be excited about the fact that 6 days a week we're eating vegetables. So again, this will be something our researchers will have to look at. So we said 6 days. Is what we're eating really going to benefit us as far as what they expect from vegetables? So there was no variation, and this I found quite surprising, that the urban and the rural is the same. But maybe the rural people, they ship it to us because they also need the money. So not most of them are eating, because I expected it to be more. Now, servings of vegetables consumed on the average per day is 2.7. So fruits and vegetables actually 2.7. The expectation or the requirement is 5. And this is where it gets tricky. 76% of Ghanaians have less than 5 servings of fruits or vegetables on the average per day. And in today's daily graphic, incidentally, I found that 40% of our locally produced fruits and vegetables go waste. It's in today's daily graphic. And we can look it up. So that actually then indicates clearly that our non-consumption of fruits and vegetables may not necessarily be due to unavailability, because 40% of it is going waste. So only 24% of us have adequate service per day. Salt. So 13% of people always add salt at the table when they are eating. 13%. no matter what, there's some salt. So it's either table salt, maybe even rock salt, or the exotic ones would use soy sauce. So, and 90.5% use salt in food preparation. So that means that salt consumption is high. And I'm sure if our colleagues in research take this up, they probably might find that the 9.5 who are not using, they have been banned by some of us from taking salt. And so that's why they are not. It's not necessarily that they've decided they will take salt. This is speculation anyway. So let's get the research done. So the other thing, sometimes I worry when I see children being given sausage and all those things, but that is commonplace as well. So 22.8% often eat processed food high in salt, and that includes Kobe and momone and kako. In fact, I found that in my magazine they do kako jollof as well. So salt intake is quite high. 9.1% think they eat too much salt, and 18.3% think they don't eat too much or they eat too little. Physical activity. So we're saying that Ghanaians who do not meet the recommended physical activity level, which is more than 150 minutes of moderate intensity activity per week, was 9.9%. So only 10% of us. But I'm sure if we do the stratification in some populations, it might be more. But this is more common in women than in men. And these age groups were actually found to be the ones who did less compared to the others. 60 to 69 we might justify, but I don't know what our explanation will be for the 18 to 29 age group. So again, that is something we'll need to look at. Recreational activity. So that's it. Some of us don't go for parties and they even play music, we won't dance. So recreational physical activity as well. The average is 12.6 minutes a day. And as we can see, for women, it's much lower compared to the men. Blood pressure. So 24.3% of us, even though checking BP is one of the cheapest, easiest, most available thing to do, almost a quarter of us have never had our blood pressure checked. That's what this room everybody has. 33% of men, maybe for women because they get pregnant, if you go to the clinic, we'll check it anyway. But even that, we still have 14.7 who have never had their blood pressure checked. As far as raised blood pressure is concerned, we found 19.6%, and it's 22% in women compared to 17.3% in men. And for severe raised blood pressure, the physicians will tell you that that increases your risk for end organ damage or target organ damage. Did I get it right? 7.3% of men have severe raised blood pressure compared to 9.5% of women. So the women are in a comfortable lead. So if we look at those with high blood pressure, controlled, 9.5%. Those that are uncontrolled, 90.5%. But the most worrying one is the proportion that are unaware that their BP is high. And this has been found in a previous Ghana demographic and health surveys as well. Our figures are actually lower. So in the 2014 one, the males who didn't know was about 80%. It's 60.6 now. And then for females, it was about 60%. It's 44.1. So I don't want to say we are making progress because this is still a huge chunk. More than half of people with high blood pressure are not aware. And to add insult to injury, 24.6% are aware but are untreated. So as a friend said, those who know how to read and do not read are no different from those who can't read because they are both not reading. So the truth is that they are aware, but nothing has been done about it. And so they are no different from those who are unaware, because they could also just, and this one, I'm sure, has other implications, whether it's the medicines available for them that are not working, whether it's a lifestyle or whatever. But I think that these are still things that we can interrogate further with research to find out what are the drivers for uncontrolled hypertension. Fasting blood glucose. The easiest one, a quarter of us. So this one is even more complicated. And some people will run away from the lancet because it's painful when you are pregnant. 70% of Ghanaians have never had their blood sugar level checked. And the prevalence of self-reported diabetes is 3.4%. So we did in the questions ask whether the person has diabetes, knows that, or has been told by a health worker he or she has diabetes. And it's 3.4%. 1.9% had their blood sugar measured and diagnosed with diabetes within the past 12 months. So again, it just shows that we could potentially have a lot of people with diabetes who are undiagnosed, 15.4% on insulin. Now, for those to be tested, the prevalence was 5.2%, and it was higher relatively in females, 5.4% compared to 5.0%. But the variation is quite significant, 6.1% in urban compared with 3.9% in rural dwellers. And the highest prevalence, which doesn't surprise some of us, was in the 60 to 69 year group. I think I mentioned earlier on, they are at a higher risk with increasing age. But the other thing of concern is what we call impaired fasting glucose. So these are people who have a higher chance of developing diabetes later. And so these are the parameters that are used. And for that, it was 10.2% overall. So if even 1/5 of that progresses, that's another 2% on top of the current figures. And amongst that, men were higher, so 11.9 compared with females, 11.3. Total cholesterol. So it gets worse because even the simple ones, they are not. And testing for cholesterol is quite expensive and not something that is readily available to everybody. Because depending on the level of the health facility, they may never ask you to do a cholesterol test. So 90% have never, and 2.3% indicated that they have a history of total high cholesterol. And 18.1% were on treatment, 17.2 male and 18.6 females. Now, raised cholesterol, when we measured, for women was 27.4%, and for men was 16%. So that's quite high overall. The next one is our weight. 9.5% of us are underweight. I haven't forgotten a news item some years ago where the opening headline, and you know the media, please don't attack me, the media, but it can be sensational. And I remember the opening statement. It said that more people now are dying from eating than hunger. I hope you get it. So more people are now, it used to be starvation killing people, but now it's overeating that is killing us. So 9.5% of us are underweight, which means our body mass index is less than 18 kilograms per meter squared. 56.3% have normal weight, or body mass index is within normal. Now, I have a friend, surgeon, who used to always fight the BMI. He says it's muscular, that's why his BMI is higher. So if you are in that group, you are not alone. But there are others, 20.9% overweight, 13.4% are obese. For them, their BMI is more than 30. As we can see, for men, it's 19.7%. if we look at the group overweight and obese. For females, it's almost half. Cardiovascular disease. So again, WHO has a criteria for what would be designated as combined risk factors for cardiovascular disease. And these could be anything from a stroke to all the others. Now, 13% of men and 8.8% of women had none of the combined risk factors. So these are them: smoking, so less than 5 servings of fruits, vegetables per day, not meeting the recommendations for physical activity, overweight or obese, raised BP, and or currently on medication for raised BP. So these 5, and as we look at it, the proportion of men aged 18 to 19 years with 3 or more was 7.3. And then if you look at females, it was 17.4, sorry. Cervical cancer. It's one of the cancers that can be readily prevented because there's a vaccine that has a high degree of effectiveness. And so it's one of the cancers that is recommended in the steps. And amongst females, again, only 3.6% have ever been screened for cervical cancer. Mind you, it's not even a one-off event, and the methods also vary in their strengths. So we have visual inspection with acetic acid, or the pap smear, which most people know, or even the HPV DNA testing. So only 3.6 had ever done that for cervical cancer. And for women aged 30 to 49, it's 4.3%. Proportion ever screened is higher in urban areas, 5.1, compared to 3.0 in rural areas. Oral health. Remember, it's one of the optional modules we added to ours. So I was expecting 100%, but 98.2 clean their teeth at least once a day. And 54.3 clean their teeth at least twice a day. And 94.1% use a fluoride toothpaste. And these are some of the options. So it's multi-answer, and so the percentage won't add up. So please don't say that the percentages are not adding up. So toothbrush is the dominant, and then chewing stick or chew stick. Okay. And then we have the others as well. 98.9% have more than 20 natural teeth. So it's just to show whether, because in our traditional setting, they say that the parent takes care of the child to grow the teeth, and the child takes care of the parent to lose the teeth. Until the dentist told me that it's not normal to lose your teeth. So it is not normal to lose it. And 98.9% of us have more than 20. I think that, and 29% had some complaints about tooth. As far as I think toothache is the commonest. 3.4% have seen a dentist within the past 12 months. But the most important one, 84.9% have never received dental care. They've never sat in a dental chair or gotten a dentist to open their mouth and inspect what is there. And I see Dr. Lenu laughing because there's more work for him. So dental surgeons, this is food for thought. Mental health. This is by far the most interesting one for me because I think that very few of us can escape it. So only about a third have no depression based on the National Health Questionnaire. The psychiatrists and the mental health people know this very well. So only a third. I remember the former CEO of the MHA once said that a lot of us have mental health problems, and it became news. But in Ghana, When we say mental health, we know what we are talking about. So we are not talking about of those of us sitting here who all look okay. Even as medical students, I remember when you came in behaving abnormally straight, psychiatry, idea of mental health. So when people are sitting with us and they are telling us emotional and psychological problems, we don't think it's mental health. We think that there has to be some medical reason. So 36.1% have minimal depression, 23% mild depression, 6.2% moderate depression. So if you combine these three, it's almost 70% or close to or 60 something percent. And that is for me the key thing. And so we need to start looking at the issue of mental health. Of course, 1.3% moderately severe depression and 0.5% with severe depression. Okay. Now, suicide. So I think recently the Supreme Court indicated that attempted suicide is no longer a crime in this country. And I think that, so, but this clearly shows that it's something, the figures were there, but I took them out because I'm sure it's not okay. So 3.8% have considered it, and 2.3 have actually attempted. And it's, in both cases, it's more in females than in male. 9.1% of them had sought professional help. So more than 90% of persons who have attempted or have contemplated suicide have not sought professional help. And it may also be because we don't have the psychiatrists available. My class in medical school were over 100. There's only one psychiatrist amongst us. So probably it's also the case. So what's our conclusion? We're saying that daily tobacco use among smokers using manufactured cigarettes is high, even though the prevalence of tobacco use in this country is low. Exposure to secondhand smoke is common in workplaces and is something we need to look at. Shisha use is common amongst the youth and especially amongst younger women. Heavy alcohol consumption is present amongst both males and females. And we have low fruit, especially, but also vegetable intake. Salt intake overall is high amongst the adult population. Our levels of physical activity are low, especially amongst women. And the same applies to rigorous recreational activity as well. Overweight and obesity are common amongst adults, but more common in women. The majority of persons with high blood pressure are unaware, more than half of them. Prevalence of hypertension is high in women. There are lower levels of awareness amongst males. Diabetes as well is similar among males and females, so the differences aren't that much. And most adults have never had a blood cholesterol test or a diabetes test as well. We've spoken about the significant portion of females who are either overweight or obese. There are more females with higher risk of cardiovascular disease. Again, we'll need evidence on the ground. Is it the case that we are seeing more females with stroke than males? Are we seeing more females with heart failure than males? Daily cleaning of teeth is high, and there's a link between oral care, good oral hygiene, I should say, and reduced risk of NCDs. So this is probably good, but we are not seeing dentists. So whether we are cleaning our teeth well, or there are things in there we are not aware of, we need to look at. So similar to my point about vegetable consumption, we shouldn't be excited about the fact that there's a high use of toothbrush or cleaning of our teeth on a daily basis. We should look at the other things. So most of us haven't accessed dental services, and a significant proportion of the population has some level of depression. Females are more likely to consider suicide given whatever situation they are. So what do we want to do beyond here? This is just a summary of what we found. There's more. There are more that we can't present even in a full day's presentation, or I dare say even a week. We're going to, as much as possible, do some more widespread dissemination. And I have given a lot of pointers to research areas we can be looking at. And I'm expecting that once we even put the results out, there'll be more research driven by the findings of this to better inform the decision making. I believe strongly, and with the technical working group for this survey, that we will need to look at our current NCD strategic plan and align them to some of the things we found in this survey so that we can now be speaking to evidence. And I think key among all of these, for me, is getting people to appreciate what this means. So when people are not eating their fruits, when 40% of our fruits are going waste, when we are doing school feeding, what is the implication for including some of these things in there? Physical inactivity, when we are designing our structures, should it be such that it compels people indirectly to exercise or be physically active without intentionally doing so? I think that some of these things can come in when we are able to engage adequately with the population so that we can pick some of these healthy characteristics and be able to pursue them. So I want to acknowledge our technical working group and particularly our superiors, the Director General Ghana Health Service, the government statistician, our former country representative for the WHO, Professor Francis Kasolo, Dr. Frank Lule, the current officer in charge of the WHO, and of course, Dr. Bafowa, who was a former director for technical coordination, and whose tenure we were able to get this done. Of course, our respective institutions, the funders, UK Foreign Office, our data collectors. As I mentioned, it wasn't easy, even for us who went to the field to supervise them. It wasn't easy for us. So for them, it wasn't easy, having to wake up very early because it has to be fasted. And if we don't take the samples at certain times, then the results are not good. So our data collectors did a yeoman's job. And for the participants, we saw a very relatively low decline rate. So that allowed us to be able to get this information. So we want to acknowledge them. And again, we want to acknowledge Professor Jacob Planjou, late, who was the chair of the Ghana NCD Steering Committee and was the first principal investigator. His big shoes that I had to step in. And he was also the head of our technical working group for this year. May his soul rest in peace. So these, ladies and gentlemen, are the summary of our findings. And I want to thank you very much for your attention.
So we can estimate all from localizing the facts and figures were to learning. To me, we started finding more there's no more online. So it's not on the agenda, but then I will want to use my discretion as a moderator to create the avenue for questions, comments, and especially the media. I'll ask that you ask questions for accuracy, balance, and clarity in terms of our reportage. So the floor is now open. If there are some questions, and I know we have a great here to answer some of the questions for us. Our health professionals are also here.
Thank you very much, and thank you, Dennis, for the presentation. There are two quick comments and queries. I didn't actually see any regional disaggregation of any of the indicators, even though it was a national representative was it intentional or what? At least the highest and the minimum would have been added. The last comment is on aphrodisiacs use. And because we are talking about non-communicable disease, that is one area of particular interest. I'm sure probably it wasn't added. But if for any reason there's going to be a next steps on and Ghana Demographic Study, I want that question is said because it's extremely relevant to our course. Thank you very much.
Okay, thank you very much, Dr. Lai, and the technical group for this wonderful work. For the sector in general, we will say this is going to help us in terms of the MNE work. I can tell you that over the past few years, and Legrafi mentioned it, the lack of national representative data of NCDs, hypertension, diabetes, and mental health. You could see that anytime we do the annual holistic assessment, indicators related to these areas are always empty. So we are happy that today we have data on these issues, which means that next year when we are doing the holistic assessment, issues concerning suicide rate, we will have data to report on. Issues concerning hypertension and diabetes, we also have data to report on. My suggestion will be that, as related to all services, these things have to be repeated at least maybe every 5 years or so that it doesn't become a one-off survey, which we may have to always refer to it 10, 15 years ago. So that will be my humble submission and recommendation to you. Thank you.
Thank you very much. We can take the last one from our participant at the last end.
Hello. All right, thank you very much. Thank you so much, Dr. Dennis. I'm happy to connect with you once again. It's been a while. My issue has to do with the DSC. Unfortunately, you did not stress so much on that. I'm here, Solomon, from the Ghana Institute. The DSC has been a worry to some of us. But then, unfortunately, because you did not stress so much on that, you only share answer out and consider that. And then I also would want to know the most prevalent risk factors in terms of the steps findings. And one area I also love so much in the physical activity aspect. How can we promote healthier eating and physical activity based on the findings? And I was amazed when you mentioned about the tobacco consumption rate, where you said 28.4 in the rural communities and 80.6 in the urban. I felt this is what the party and everything happens. Goes in the village and then the rural community. I don't know if you can tell us why the rate was very high in the village, but what the real things happen, it's rather on the ground. Thank you very much.
So I think we'll take the last one. I understand there will be a discussion after this. We'll leave all our comments for that session.
Ladies and gentlemen. So my question has to be on the fact that we need to add more fruits to our diets. It was also stated that fruits mostly go waste. So my humble suggestion is, with the school feeding program, why don't we add fruits to the diets of the students, whereby students have fruit as their diet so that the other fruits not go waste. Thank you.
I'm ready to respond to some of them.
Thank you very much. So, please, I only presented. I only presented for the group. So I will give my feedback and I'll let allow for this also to respond to some of them. I think the last one, I propose that. But again, it's just a finding. It's something I found in the newspaper to do. And so we need to look at it. And the fruits that are available where they are eating. Because when I was a child, those who grew up where I grew up, knew that those like we used to plant mangoes like 20 and you sat with a bowl of water and you raised the ears too small, 20 or 40 pieces at a bowl. That was how they were eating fruits in season, as and when they are available. But this is deliberate fruit consumption we're talking about. So again, as I said, if that's evidence that can be used, we can do that. The certification, I think, Dr. Paul would address that. Aphrodisiac use, so I think implicit in that, because I know that alcohol consumption is sometimes driven by that. So again, I think that is something we can let research drive. So based on this, can we then find out what proportion of people consuming alcohol are actually taking it for aphrodisiac purposes, for example, capsules. And then, okay, then the capsules and the others. Yeah, so that we can look at those. They need to be survey. Yeah, I think the partners are here. They've had it. So in the next 5 years, we should have it. PSA, I'm not a urologist, so I don't want to go to that space, but I know that it's not a recommended screening unless there's a risk factor. So there's a family history of prostate cancer, and it's recommended for screening. So you won't do routine screening for using PSA unless there's a risk factor. So that's why it was not included. This one is not gender, as I know cervical cancer was in there. So that's why my friend raised that. How can we promote healthy eating? The Director Health Promotion Analysis is here, so maybe she will answer that. I see some of the staff also around. So. And alcoholism in rural areas, why we are surprised is more. Maybe research to find value. There are limited options for payment. Maybe that's what the matter. This is me just a minute. So maybe you don't have the power to address one or two.
All right, thank you very much. With alcohol, I think we all know that some of the local drinks that are palm wine and those type of drinks are from the rural areas. So it's easy to have access to it. So it could be the reason why. But let me come to the question of regional variations. I think in my submission and even from the presentation, we got to know that this is representative household survey. The selected illumination from the presentation were we got to know that this is representative household survey. Proportional to size. So, in doing further analysis, we can look at the regional variation. Particularly in this publication, we have some of the indicators being analyzed at the regional level in the main report. So when you get access to the big report, you will find some of the figures in at the regional level. But I think we were silent on that because this, as we all heard, is the key findings from the main survey, and we wanted to present it at the national and then by urban rural level. And of course, by male female, as we all saw what was displayed. All right, thank you. Thank you very much.
Okay, thank you very much. So, distinguished ladies and gentlemen, now we have gotten to the climax of today's event, where we get to hear our keynote speaker speak to us and also officially launch the STEP Survey 2023 report. But before we call on our keynote speaker, I want to take some few minutes to read a little profile about him. Our keynote speaker
is a qualified medical doctor. He also holds a master's degree in hospital management. He has attended and shared his experience at several local and international workshops, seminars, and trainings relevant to his area of expertise, healthcare management. He is a seasoned hospital leadership and management expert with over 29 years of experience in hospital management in both the public and private sectors. He has held several hospital management positions, including serving as a medical director of a secondary level healthcare provider in Cape Coast, Ghana, now a tertiary level healthcare provider the Cape Coast Teaching Hospital. He holds he has he also led the transformation agenda of one of the most successful quasi-government hospitals in Ghana, the Trust Hospital. Aside leading the service provision expansionary drive of the hospital as the general manager, he led the establishment and opening of 8 new branches, which are doing very well. Due to his prowess in leading hospital management and transformation, he was appointed in July 2018 by His Excellency the President of the Republic of Ghana as the first ever Chief Executive of the University of Ghana Medical Center, UGMC, with the mandate to operationalize same. The UGMC is designed to become the first quaternary level healthcare provider in Ghana with the intention of serving the West African sub-region and beyond. Currently, he serves as the technical advisor to the Honorable Minister at the Ministry of Health, leveraging his expertise to inform policy decisions and drive healthcare advancements. Distinguished ladies and gentlemen, I present to you Dr. Darius Kofi Osei, who is our keynote speaker, and he will also officially launch our survey.
Thank you. Thank you very much for your kind words. Excellencies, ambassadors, heads of agencies of the ministry, representatives of development partner sector lead, development partners in health, distinguished guests, friends from the media, ladies and gentlemen, good afternoon to you all. I am honored and humbled to address this important gathering today with no other agenda item than non-communicable disease, which affects every facet of our lives. This gathering comes at a critical time as we deepen our resolve to address the menace across the African continent. I am proud that the health sector has achieved this milestone of conducting a step survey study for which we have listened to the alarming results of our country. Over the past 10 years, non-communicable diseases have changed the world. NCDs have become the leading cause of death in most countries, resulting in 150 million premature deaths among people aged between 30 and 70 years, most living in developing countries. Consequently, the growing burden of NCDs represents a major challenge, not only for developed countries, but also for developing countries. The risk factors underlying major NCDs, heart disease, stroke, diabetes, cancer, and respiratory disease have been well documented and are well known. Ghana has witnessed an increasing trend in the burden of NCDs and has modest progress has been achieved in addressing this increasing burden. However, current health management information systems are both inadequate and unreliable to provide a robust evidence-based data on NCD risk factors to inform effective policy response. The STEP survey conducted is really to provide baseline data for more effective monitoring and surveillance, as well as track national global progress and understand Ghana's performance towards achievement of the global targets of NCDs. Ghana has committed to implementing the 2030 Global Action Plan for NCDs by taking a cost-effective public health approach to address risk factors such as fiscal measures, taxes on tobacco, alcohol, sugar-sweetened beverages, school and community-based health promotion, among other critical interventions. Again, Ghana seeks to advance reforms in social insurance, in human capital development, as evidenced by ongoing policy discussions, better quality data on NCDs and their risk factors, which will provide critical information for policy design. As I conclude, I take this opportunity to congratulate all stakeholders who have contributed significantly to achieving this milestone. Special mention is made of Government of Norway, World Health Organization, UK Foreign Commonwealth Development Organization, and Ghana Statistical Service. The Ministry of Health and partners are committed to using this evidence generated not only to inform policy, but also to serve as a strong advocacy tool for public education and to facilitate resource mobilization at both local and international levels. On this note, I officially launch the first nationwide STEPS report for Ghana. This time, I begin the Ghana STEPS report. Launched.
Yes. So our essentially development of the high table, please come back for us to table to us. Okay.
So, Dr. Lai and your team, kindly join them for us to take a photograph. The technical working group, kindly join them.
partners and agencies of the Ministry of Health and all other agencies how far we have come with their support. The next was Mr. Power, FC of UK. He expressed gratitude to all those who have made it within the 64.8%, and that's the frequency for daily use. He also highlighted the alcohol use, where he indicated 52.6%, and if you are looking at gender parity, say 30.6% for males and 14.5% for females. Rural issue was another shocking thing, because he said as high as 28.6% for rural and the urban 18.4%. And on that, people were arguing how come that the rurals have overtaken the urbans in terms of alcohol consumption. And so some of us were saying that in some of the villages when you go, sometimes they don't have TV, they gather and they sit down. What keeps them together is alcohol. And so sometimes these are some of course it requires better studies to ascertain that. He indicated the lifetime abstinence, so 43.9%, and for the past 12 months, abstinence 19.8%. I'm highlighting this so that people know the direction that we are going in terms of alcohol consumption. The next item had to do with diet. He indicated that diet, in terms of diet, 2.2 days in a for most Ghanaians' intake of fruit and 6.0 days in a week for vegetable consumption. Now, both rural and urban have the same rate in terms of our society. The next item we look at was the salt intake. They indicated that 13% add salt to their diet, and the 98.5% use salt.